months after transplant that they can write letters back and forth, and then we are the go-between. So the recipient family can write a thank you letter and send it to us, and then we'll forward it to the donor family. After that 6 months, if both parties are agreeable, then we can release addresses and they can kind of take the relationship from there. It used to be a year waiting period just to allow for grief and for healing, but with social media, we found that a lot of our families were finding each other a lot sooner anyway, and even 6 months. Like, we have families that within a week or two have found each other on Facebook. So I don't know if that's the most healthy sometimes because, you know, the trauma and the grief, but we do what we can with that. I had another question over the break about what kind of training do I have? Well, I'm a nurse. I'm an associate's degree nurse. I'm working on my bachelor's right now. You don't have to be a mid-level. You don't have to be a nurse practitioner for this job. It's just a lot of training. It's a lot of critical thinking. And you really have to believe that this is the job you want to be at for 24 hours at a time. It's not just a job, it's a lifestyle, for reals. But people are always like, oh, I want to work with you, I want to do your job. Well, that's great. I want to work with you in the hospitals. Because if you're going into critical care, the chances of me working with you or you talking to Midwest are pretty high. So get good at your job, and you know, things sometimes can just fall into your lap, which is what happened with me. So were there any other questions that anybody had over the break? Okay, good stuff. So we're going to talk then about the transplant side of things. And I am not a transplant coordinator. It's weird as it sounds. I am an organ procurement coordinator. So there is a counterpart of mine on the other side that is the transplant side of things. Again, we try to keep things very separate. So I reached out to one of the local kidney transplant institutes, and this is a lot of the information from them. So my experience is very limited. I did care for transplant patients. I worked in the MICU at St. Francis for like 7 or 8 years before starting this job. So I cared for some of these transplant patients. So I'll kind of pull on those experiences as well. So the objectives for this presentation are just a brief history. Again, you don't have to know the history of transplant, but I always like to just throw it in there. Identify the signs and symptoms of transplant rejection, the interventions for rejection, and then some common complications of transplant. Again, lots of numbers, but it's relatively recent stuff. The coolest one is down there in, so 1954 was the first successful kidney transplant. It was a twin-to-twin, identical twin-to-twin. The donor, I think, lived to be 79 years old, and then the recipient lived for 8 years after the transplant. But 1954 was when that happened. But in 1947, so 7 years before that, was actually the first kidney transplant in the United States. And it was a young female in septic shock. She was actually in toxic shock syndrome from a bad abortion that happened in 1947. She went into acute renal failure and coma. So they call it a cadaver kidney. So they took a kidney from somebody that had been deceased and transplanted it into her arm. And they hooked up the arteries and the veins and left the ureter out, kind of like a JP drain. And as soon as that kidney received blood, it started filtering the blood, and it was able to act as a temporary dialysis, kind of like just an acute situation. And it was enough to get her through that coma situation in the acute phase. And 2 days later, she woke up and they removed the kidney, and she lived. So the first type of dialysis kind of thing. But because the time frame was so short, they didn't have to necessarily worry about rejection and all the things that happened. And I think they just said, she's going to die anyway, why don't we try it? So beyond the experimentation, like I mentioned before, with the advent of hemodialysis in the 60s, end-stage renal disease it wasn't a death sentence. You could start living longer on dialysis with this. But it became very expensive to pay for disability. The diagnosis of end-stage renal disease is an automatic disability. So you can go on disability, and it's very expensive for the government, for healthcare to pay for. So then they said, well, we need to start paying for transplant. Why don't we get these patients back to normal lives, activity, they can go back to work, be part of society. The turning point for transplant was actually the development of cyclosporin, and when it became available in the late 70s. And has anybody had a patient, like in your clinicals, that has been a transplant patient, ever cared for anybody? So, yeah. Yeah, kidney transplants or just lungs? Awesome. CF clinic? Or, okay. So then Prograft became available about 10 years ago. So cyclosporin and Prograft, those are the two big hitters with anti-rejection meds. So getting started to be worked up for a transplant, you have to have, and I put in parentheses, it's just insert disease here. So you have to have renal disease, heart disease, lung disease, whatever disease it is. You have to have the desire to be transplanted. This is not something that you can force on anybody because you have to be so compliant with the treatments and the therapies afterwards that you can't be forced into this. You have to be very willing. You have to be willing to get educated. There's a huge amount of evaluation that happens, and you have to be compliant. Have to. Some of the numbers with this, so if you, a deceased donor transplant, so one of my patients would be considered a deceased donor transplant. So if you get a kidney from one of my patients, then you have an 85 to 90% success rate at 1 year. Those are good numbers, pretty decent numbers. The organs recovered in the OR, it has to be, the kidneys can be outside the body for up to 24 hours before they have to be transplanted. So there's some time, wiggle room there. Of course, the shorter amount of time outside is better. All the other organs are a lot quicker than that. It ranges from heart and liver are about 4 to 6 hours. Lungs are up to about 10 hours before they have to be transplanted, and then kidneys can be up to 24. You have to notify your clinic, and this is the case with any transplant, obviously. If you have a change of address or phone number, they have to be able to get a hold of you. If you leave town for any reason, you're planning a big vacation, you have to notify your transplant center. And then if you're unavailable for any reason. I actually have had where I've made the offer to a recipient, particularly for a liver, and the coordinator calls me back and she's like, this offer looks great, I'm excited, I'm gonna call my recipient. And 10 minutes later she calls me back and she goes, well, we're gonna have to decline because my recipient went on vacation down to Florida and he's unavailable. So they had to decline the offer and I went down to the next patient. He hadn't told the center, because you can be put on hold, you know, that type of thing, because I'm sure he just thought, it's never going to happen, I'm going to go for this vacation, but he didn't think to call his center, because they could have maybe had a plan of, how can I get back, that type of thing. And then if you have any change in insurances or change of work. So if you have a living donor transplant, so this would be like a living related, say you get a kidney from your father or your brother, you have a 95% success rate. It's usually a sibling, a parent, or a child, and that is because we get 3 antigens from a father and 3 antigens from your mother. So if you're trying to find the best match to match up all 6 of those antigens on your DNA, the best pool would be from a full-blood sibling. So when they go to try to find a living related, you're going to try to find probably a full-blood sibling first is going to be your best bet, and then from there it's going to be a parent probably, and then a child from there. You have fewer rejections and fewer infections if you have a living related or a living donor. Sometimes you're not related, sometimes it just happens. And that's just because, how we talked about before, the process of brain death can be quite crazy on a body. And so that may have some effect on the transplanted kidney, liver, heart, whatever. This surgery could be scheduled, so you don't have to just be waiting for that call. Did I miss a call? Can I go on vacation? And you don't spend any time on the waiting list. So if you have somebody that's willing to donate a kidney to you, you can have that scheduled after all of the thorough evaluation. They can also do partial liver. So you could donate 1 lobe of your liver to somebody, so you could be a living liver donor, which is crazy.
So just kidney and liver?
Kidney and liver, yep. Some people say lung, or they ask about lungs. We can't do that yet. Who knows what's coming. So evaluation, it's usually several months worth of evaluation if you're being worked up for a transplant. Medical, you talk to your internal med people, you talk to surgeons, you talk to psychologists, cardiologists, pulmonologists. You usually get a colonoscopy if you're of a certain age, heart cath, infectious disease, the whole 9 yards. Because they want to make sure that you don't have any pre-existing things besides your renal disease, if that's the case. You have to maintain a healthy BMI. Again, I've had patients that get the offer and the coordinator calls me back and says we're going to have to decline because I just talked to him and he was up 15 pounds from his last 3-month check-in. So he's going to have to be put on hold because his BMI now is too high. So it's for real. Like, it's not something that you mess with. And legitimately so. I mean, if you're going to get this huge gift that somebody's giving, you need to be able to take care of it. You have to have a way to pay for your medication. So this is why you have to have a form of insurance. Because you can't, this is not something that you will take for 10 days and then be off of like an antibiotic. This is a lifetime medication that you will always be on. And then most patients have to have blood drawn twice a month, at least, if not more. I did want to go back and just touch on the evaluation part of this. I took care of a patient, he'd gone through all the process. He actually was a kidney recipient and received his kidney, did well post-operatively, spent 24 hours in the ICU, went out to the floor, and did okay. Till about day 4 or 5, his kidney started to fail. So they started doing all the tests and working his kidney up, and they found that really his numbers looked good. It didn't look like he was in rejection. But just in case, they transferred him to the MICU, where he became my patient, and they started him on a Prograph drip, which is done through IV. You have to draw labs like every so often. It's a crazy process. So we started caring for him, and he just didn't seem to get better. Like, even though his numbers looked good, he just didn't get better. Like, mental status, just we could not figure out what was going on with him. Consulted everybody to come in and see him. And it wasn't until we consulted and had a psychiatrist come in and see him because his wife said, I think he's depressed. So psychiatrist came in to talk with him, and it was then discovered that at the hospital where he received his transplant was also the hospital that cared for his donor. And not only was it the same hospital, it was the same ICU, and it was the same nurse. So the day of his transplant, after he woke up and was in the ICU, overheard 2 of the nurses talking out in the hallway about, hey, was this that 16-year-old that was the donor yesterday? And they started talking about his donor. So he knew immediately that this young 16-year-old kid was his donor, and it was around the holiday season, and so he knew that there was a family out there that was suffering and grieving during this holiday season, and yet he had this new gift of life, and he was struggling internally with, why is my life more important than the 16-year-old kid's? So even though everything medically looked great, and you go through all this evaluation and you think, yeah, I'm ready for this, sometimes the mental part of it or the psyche part of it, you're just not quite prepared for. And that was his issue. And so just working with therapy with him, starting antidepressant, all that kind of stuff, he got better and he did just fine. But it took a little bit to try to figure that out. So it's not just as straightforward of, yeah, everybody's so happy to get this. It takes a little bit. So ABO typing or blood typing, just like with any blood transfusion, organs are the same way. So O can go into anything. O is the universal donor. The AB is the universal recipient, and then it kind of goes down from there. So tissue typing. One of the other questions I had during the break was, do you ever get to the point where you don't find a recipient because of the typing that has to go on? So we get, like I said, we get these antigens from our family, and they result. You don't need to know this. You don't need to know the name of them. I'm just telling you them. You won't be tested over this. But these are what we test. When we are looking for that perfect match for a recipient, it's not just blood type. It's not just size. It's also it's a deeper layer than that. So we're looking at their antigens that they've developed. We, especially with kidneys, we have to be very picky because a lot of these end-stage renal disease patients have received blood transfusion after blood transfusion on hemodialysis. Some of them haven't, but with every blood transfusion, you introduce a new set of antigens from that donor. So what would be some of the things? So let's talk about this PRA. I just wanted to mention this. That this PRA, these are what patients get blood drawn twice or monthly sometimes if they're drawing this. So PRA is the panel reactive antigens. So if you or I were to go in and get this PRA tested on us, my PRA would hopefully be very low, meaning that if I were to be matched with anybody in the United States, I would have a low likelihood of reaction with them. So my percentage of reaction would be very low because I don't have very many antigens. I haven't been exposed to blood transfusions and all this other kind of stuff. But if we have a potential recipient that has been exposed to, maybe it's a redo, maybe it's a second one for them, and they test and their PRA is 98%, they have a 98% likelihood of failing their match with the general population. So when we find that 2% that they don't have a reaction with, it's like this huge it's a huge celebration. So when we have like a 99% PRA that passes our cross-matching, it's a big deal because we have found the 1 or 2% that they hopefully won't have a reaction with. So the higher the number, the harder to find the match. And if you get your PRA increases every time that you are introduced to a new tissue. So if it's a previous transplant, like I mentioned, blood transfusions, and then there's another one that people never think about, and it's pregnancy. So the number of pregnancies you've had are also going to increase your PRA because your body has created an antigen against a foreign tissue, against a foreign body. So vaccines, some vaccines, like if you have live vaccines, you'll have an increase with that, but generally you're not going to get a live vaccine unless you're in a high risk, military type thing. But that's just something to remember. And not that you're going to not transfuse your patient if you need it, but again, every time you introduce something foreign, your body creates an antigen to it. Yes?
And just a quick question. On the PRA, let's say you find that rare 1% lung or something like that. Does that put them up higher on the receiving list of that organ?
Yes.
Okay.
Yes. So did everybody ask or hear that? So if we find that they're in the 1 or 2%, so when we enter in my donors' demographics, their blood type, all of that kind of stuff, then from there, there's just like this magic little algorithm that happens when we enter in all of their HLA. So the recipients have already had this HLA done. So their information's in the master list. We put my donor's HLA in there, and then from there, this whole thing happens. And then at the top of the list, especially with kidneys, is going to be those patients that have this 1% chance. If every once in a while, so PRA and HLA are a little bit different. So HLA are what you are born with. Those are like your DNA. The PRA is what you can develop. So every once in a while, there's an HLA that match almost exactly up on your DNA. It's not like your identical twin, but they match at the same spot on your DNA. And if those happens, it's called a zero mismatch, meaning that the stars have aligned and you have found a perfect match. And if that ever happens, that patient, they could have been number 2501 on the kidney list. They get bumped to the very top of the list because they're going to have the best outcome of graft survival because you're not going to have to worry as much about rejection. So that's always pretty cool when we get a zero mismatch or a perfect match. Yes. Yep. They're still put on anti-rejection. Yes.
So how does that work, like with bloodless transplants, like for Jehovah's Witnesses?
Jehovah's Witnesses. So I am not familiar with the bloodless doing the transplant. I do know that they can do transplants and not receive a blood transfusion. Absolutely. And I would say a majority of them anymore are probably that way. Oh, absolutely. Yes, absolutely. Everybody has to get that amount of typing. It's always interesting to me that they won't receive blood transfusions, but they will receive solid organ transplants. Yep. Yeah. Right. Yeah. That's sticky. It always makes everybody a little bit more nervous. Yeah. But it can happen, for sure. So the surgery, again, this is particularly for kidneys, but it's going to be a lengthy surgery. I will tell you that the person who recovers the organ that comes to my OR is usually not the same surgeon that does the transplant. Because if my OR has been a 4-hour surgery, he takes it back, and to transplant that heart could be another 4, 6, 8-hour surgery. So they always hand it off to then a transplanting surgeon. It's rarely ever the same surgeon that does the recovery because it's such a long surgery. The kidney, and this is the only time that the kidney is not placed where the native kidneys are. So the transplanted kidneys will be placed in the pelvic area, right down here front. The native kidneys, or the original kidneys, are left. They don't take them out unless there's a reason to, like cancer. Because most of the time it's a less invasive surgery to only do one surgery. Because if you have to take them out, then you have to, the chances of bleeding are a lot higher. Your adrenal glands sit right on top of your kidneys, and you'd have to mess with all of that. But if you can leave your adrenal glands functioning, that's great. So most of the time, the native kidneys are not removed. You spend the first 24 hours in the ICU. And if you're a thoracic recipient, I would probably venture to guess that you're going to spend more than 24 hours. We get updates on our recipients every once in a while. Like I'll text with the coordinator. Like if I put a lot of effort into something, or I know the recipient was really sick, I will, like the next day after surgery, I'll text with the coordinator and say, hey, how are our lungs doing, or how's our recipient doing? And they'll say they're great. Either they got extubated this morning, they're up walking the hallways, or the heart recipient came off dopamine and things are good. Or they'll say slow weaning, the whole 9 yards. But you always will spend some time in the ICU afterwards. It is like you are going to get up and walking as soon as possible because, again, just like these cabbage patients that are up moving so many hours after cabbage is just amazing anymore. And you will be hospitalized for up to a week and sometimes longer. Majority of that time is going to be spent figuring out your medications. It may not be that you medically need to be there, but they've got to do lab work and medication levels, and you have to be educated before you leave the hospital. So immunosuppressant. So these are the meds that a transplant recipient is going to be on lifelong. Not all of these, but maybe a mixture of some of these, at least one of them. And they're used to treat and prevent rejection. So, you may only be on Prograf, but maybe when you are going through a period of rejection, they may add something else to you. You have to, like I said, that week spent in the hospital is going to be a lot of education, and you have to be able to, I think previously, at least the coordinators that I've talked to, they hand a patient a medication outside of a pill bottle, and they hand it to them, and they say, okay, what is this? They have to be able to recognize what that pill is, what the dosage is, and why they take it and when they take it. So they have to be very knowledgeable of their medications. A lot of recipients wear a MedAlert band of some kind because you don't ever want to take another medication without letting your transplant center know that you're taking a medication. You don't just go to the ER for a sore throat and get prescribed an antibiotic. You wouldn't ever do that as a recipient. You always want to run things through the filter of your transplant nurse, and you have a coordinator that's assigned to your case. And then again, you would always need to make sure that anybody caring for you is aware of that you're a recipient. Even if you were in a trauma, if you come in, because if you don't get those meds, bad things can happen. And you can never stop taking your medications. That's the biggest thing with compliancy. That the study shows that the most common cause of organ transplant loss after 5 years. So you've done great for up to 5 years. You're probably thinking, okay, things are good. I'm going to slack off. I'm not going to finish that last 2 days of antibiotic. Who's done that? And then up to 30% or more are lost due to just occasionally missed doses. So you kind of get comfortable and a little bit complacent. You have to remember that transplant is often a form of treatment. It's not a cure. So if you have had a kidney transplant because of diabetes or a kidney transplant because of hypertension, you still have hypertension and most of the time you still have diabetes. So it is a cure, and you can certainly kill your transplanted kidney and need another one. The same is said with alcoholism and liver transplant. And all centers have rules about you have to be clean, and they do drug screening. You have to be clean for so many months before you're even listed, and then you have to stay clean or you get unlisted pretty quickly. So rejection. So rejection is the body's normal response to a foreign object. So you get a sliver in your finger, Your body says, that's not normal, we need to get rid of it. So it sends white cells and you get all red and inflamed and it hurts. So that's a form of rejection. That's your body's way of saying we gotta get rid of that. Most transplant patients will experience at least one episode of rejection, and usually the first 3 months is the riskiest period. It doesn't mean that the kidney has failed, that it doesn't mean you have to go back to surgery and have it removed. Everybody goes through some form of rejection, whether it's mild or not. There are drugs to treat rejection. These are just some of the maintenance medications. I put these in here just so you are familiar with what they are and the names of them. I would ask that you reach out to your books if you have them about these meds, because I am not the expert. Again, you're going to be on one or multiple of these. The big thing to remember is that they have to be compliant with them. Some of the signs of rejection are a fever, flu-like symptoms, ache, fatigue. If you're a kidney transplant, a decrease in urine output. If you're a heart transplant, maybe it's signs and symptoms of fluid overload. If you're a lung transplant, maybe it's that you're short of breath. So any signs of the disease would be the signs of possible rejection. Tenderness and redness over the transplanted organ, obviously that would be hard to tell if it was your heart that was getting all tender. And then you contact your team. They would rather take 15 calls a day from you than miss the one call that you should have made. So contact your team with any questions. So these are some drugs that are used to treat acute rejection. So these are they've said, yes, I'm in rejection, you're going to be in the hospital. A lot of these are going to be given IV. So thymoglobulin, corticosteroids, radiation therapy. Radiation therapy is not done very often, but I did put it in there because it did list it as a treatment. And it's very focal or focused. It's like at the kidney, and it's used to just destroy the cells, to just radiate the cells. And then OKT3 is another one. I did kind of type out, I'm not going to go through each one of these, you guys can read that, about which one each one is. Steroids, those are the ones that are always, people are always on steroids. Radiation therapy. Some of the drug highlights, lowlights, like with anything, there's going to be side effects with them. And this probably is what leads to the non-compliance, is that the side effects are, nausea, vomiting, diarrhea. Sounds like a good time, right? But compared to, I can't walk across the room without driving oxygen, it may be worth it. So, common complications of transplant. Bleeding is always a big one. Thrombus, when they re-anastomose the arteries and the vessels, thrombus is always a big deal. We, in the organ recovery OR, we always flush the organ very well with a preservation fluid because we want to try to get all of the blood out so that there's no chances of thrombus or clots forming. You can have delayed function, and that could just be because the organ is just a little bit stunned from going through whatever it is. Doesn't mean, again, that the organ is bad. You just may need to give it some time. Then there may be donor-related issues. So sometimes we'll get a call from the heart transplant center and say, hey, my donor or my recipient's just not doing right. Have you had any other calls? No, we haven't, but we'll reach out. So then we call the lung transplant center and check and say, hey, what about this recipient? Is he doing okay? Well, yeah, we've kind of had some funny. So then we're like, okay, is this a specific donor-related issue, or was this just maybe something going on with the recipient? But sometimes there are things that are donor-related. Then we call all the other centers to say, hey, what's going on? So those are just some common complications. I know we are done with time, but the next slides I have are kind of a name that organ type slide.